Page 34, we continue, and that's a dependent assessment. What is dependent mean? They're depending on other. They're passive. Active means you do it, passive means somebody else does. So they're more passive people are. And also problem working independently. And so they cannot work their own. Help when alone, helpless. They feel very helpless, they cannot take care because they're dependent. So work is dependent, they depend on other people. They're helpless and dependent on other for decision. They are afraid for loss of support and approval. How do you do for them and what do you do? Dependent people emphasize decision making, help them to make a decision. Teach them assertive. What is assertive? Word is that you make sure you can do it. You are assertive to do. We all are nurses. In our question, are you going to be assertive nurse? Yes, you know what to do. Assist to clarify feeling and need. If they need some help, ask them and you help them to make decision. Avoidant word is they avoid. Avoidant, socially uncomfortable, hypersensitive to criticism, and lack of self-avoidant means they are not confident. So they are lacking, underline the word self-confident. Fierce, intimate relationship. They are afraid to make a relationship. Avoidant people, what do you do as a nurse? Gradually confront their fear. Ask them, why do you avoid? What help do they need? Why they are fearing? Discuss their feeling. Teaching assertiveness. We all should be assertive, that we can do things. Increase exposure to small group. Let them work in a small group because so they don't avoid and they can come out and they can work together. So now we have even a simple problem, but mental health is a problem. You cannot function and you do have people who are dependent and avoidant. Obsessive compulsive disorder, OCD. I want you to write down in OCD on the side is neurosis word. What is neurosis? Is nervousness. See, there is a psychosis is, I said, is a problem with psychosis. They have a thinking process and that's why they are having a problem with their behavior. But obsessive compulsive disorders are, underline the word, high standard. Everything they want to be perfectionist, high standard for self and others. Whatever they're doing, the living standard is high. And also preoccupied with rules in their mind, cleaning. Whatever they're doing, they have a rules and regulation and they follow that rule and also organized way. They're perfectionist, intellectualized. They know they are intellectual. So OCD people are more perfectionist people. What is the word OCD? Obsession. Write down the word obsession means thought. In their mind, whatever they're thinking, and compulsion is ritual. So write down compulsion is a ritual. So in your mind, cleaning is important. So what they do, they're busy in washing hands, cleaning. So obsession is a thought, compulsion is a behavior. And they are neurosis people, and a lot of people who does, they have anxiety level. And so explore the feeling, find out what they're feeling, why they do this, and help with decision making. Sometimes you have to teach them how to make a decision. Is okay sometimes to do this way, and confront procrastination. Now, procrastination word is they don't make decision for others. So they are procrastinated. That means they only want to do same thing over and over, but they don't want to do other thing. Teach that mistakes are acceptable because they are perfectionists. They have to learn life is normal and you do make mistakes so they can accept that. So what do you do if they give you a question, OCD? I want you guys to write down there, let them continue the rituals. That is your first answer. What is your first answer? Whatever they're washing hand, just don't go and tell them stop washing hand. Let them continue the ritual. That's number one. Number two, slowly involve them in other activities. So what do? You try to take their time and put them in activities. So number 2, involve them or direct them in another activities. Number 3, safety is important. If they're washing their hands are safe. Whatever they're doing is not good. And safety. Check their weight, because they may not be coming out to eat their lunch and meal. And also write down the word is plan, and written planning, and written schedule. Write down the word written schedule. And the meaning is, what are they going to do every 2 hours and 3 hours? You make a plan. Now 7 o'clock, let's go for breakfast. 11 o'clock, we want you to come out in the dining room. 6 o'clock, let's go for dinner. 2 o'clock, we have activities. So what do? Make a written. What is the meaning written plan? Your patient sign and you sign as a nurse. And so when you're telling them why they haven't done, they're not going to say, I never promised you. I don't know what you told me to do it. So remember, what do here? Is you do a written plan. Everyone is okay. OCD is not psychosis, it's a neurosis. What is your first answer? If you have a patient, whatever they're telling you, and they're telling you what to do, never pick up and say, stop, you're washing your hands. Stop and come out. No. Let them continue the ritual. So these are your answers for OCD. Manipulative behavior. A lot of people are manipulative. What is manipulative? Unreasonable request for time, attention, and favor. They know when to get their favors. They know what they want. So they're manipulative, people are. Divide staff against each other. They make people fight because what they're doing, they're very manipulative. They go and show they're good, they talk about others, and they against each other. Intimidate. They make other people feel they're very superior because they're manipulative, they get their work done. And also use seductive and distinguishes approaches. Now they do get away with the thing because they are manipulative. But remember, manipulative is not good. How do you do with them with manipulative question? Underline the word, use consistent, undivided staff approach. Use same approach for everybody. Don't give favor. Now what they're manipulative. They come and make friends and they want to get their work done. But whoever is doing that, you don't let them get the favor. Are we clear? That means you do same approach for everybody. Set limit. Let them know that they cannot get by. This is the limit. Set limit is always good in all your answer. Check for destructive behavior. Help and also to see consequence is of the behavior. They all should know. If you manipulate this is not good because the consequences you have to face if something goes wrong and they're responsible. So these are the wording and I want everyone read it, understand, very simple, and that goes in mental health. Now we will go alcohol and question intoxication. So let's move on to the next page, number 35. And when you have acute alcohol problem or alcohol intoxication, the person are drowsy, tremor, underline the word, impaired thinking. And next is impaired thinking, tremors, very important, slurred speech is there, and loss of inhibition. That means they are not interested in a lot of things. What is alcohol? Remember, is a depressant. It depresses the person. And assess for injury, withdrawal, monitor for withdrawal, give them IV glucose, and also counsel for alcohol use. You need to talk to them about alcohol problem. Alcohol withdrawal assessment. Now the question is, what happened when they're withdrawal? So number one, we all remember they have tremors, insomnia, very important, they cannot sleep, and it does cause anxiety, and then you go hallucination. So they can also be hallucinated. After withdrawal, what happened? They go into delirium. So very important in alcohol withdrawal, insomnia, hallucination, tremor. Then after their withdrawal, then what happened to them is disorientation. Then you go, is suicidal, very important. And last one, convulsion. So we all should know they have tremor, insomnia, convulsion. So sometimes you get a question, your patient has alcohol withdrawal, what do you monitor? So those are the things. Now, implementation. What do you do as a nurse if your patient has alcohol withdrawal? Vital sign, number one, check, administered sedation. What do you give them is sedation. And also anticonvulsant, underline the word thiamine. We said about thiamine before. And also glucose, so very important, thiamine. And then seizure, they can go. Quiet room and less lighted. Quiet, well lighted so they can see, but quiet room to prevent seizure and let the family members stay. So number one, thiamine is important. Anxiety medication, I want you to write down when they come with immediately alcohol withdrawal, Ativan, you can give them as anxiety medication, and write down the word Librium. Librium is given for your patient with alcohol withdrawal. It helps them to control anxiety. The next thing is chronic alcohol patient are persistent incapacitation. Incapacitation, they don't do a lot, incapacitation. Cyclic drinking or binge, they can drink a lot of time, they can drink a lot. And family violence. Now some people, when they become chronic, they get angry easily and they start violence in the family. Alcohol dependency is patient who are dependent on alcohol is identified. First thing is you got to know the problem, help the client to know and see the problem, which is hard. They don't accept that they have a problem. Alcohol AA, write down the word AA on the side, is for your patient. Then is antabuse. They got to go on treatment, and that you can give. So antabuse is given for chronic, not acute patient. Acute you will go for Ativan and Librium. Antabuse you will go for treatment. Wernicke syndrome means the alcohol damaging the brain. And what is it damaging here is cause confusion, diplopia, and also nystagmus. Nystagmus is abnormal eye movement, ataxia. And so remember, a Wernicke syndrome means is affecting the brain. They're getting more confused. How do you treat them for Wernicke syndromes are, underline the word thiamine, IV, or IM. And try that they are away from the alcohol, which is hard, but that's the treatment, that abstinence from alcohol. So Wernicke's means affecting the brain, thiamine is important. Korsakoff is same thing, is psychosis, they are affecting the brain. Learning problem, it's hard for them to learn. Memory disturbance, altered taste and smell, relatively is loss of reality testing. They cannot understand the reality. So when you have Korsakoff again, it's affecting the brain. They are altered the taste of their food, memory disturbance, and also reality testing. What do you give them? Balanced diet, thiamine, and avoid the alcohol. So everyone, thiamine, Ativan, Librium, and antabuse is important. The word Wernicke's cough, Wernicke's is for the mental problem that it affects, and Korsakoff also memory person is affected. Retinopathy. Retinopathy is on the other side of the page on 36, right on the top, in premature baby. Now why in premature baby? Because they are having lack of oxygen and you are giving too much of oxygen. So retinopathy comes in the newborn babies, especially premature. It says premature. Determination line with rich retinal detachment. So check the retina. So what do you do when you're giving oxygen to the babies who are premature? Check their eyes and retina. And they may also go retina detachment. So how do you prevent retinal problem in the newborn babies? Monitor using of oxygen concentration. Monitor O2 level. an eye exam. So a lot of questions come, what is the problem when you give too much of oxygen in premature baby? Your answer would be premature retinopathy. How do you treat them? By eye exam and check the oxygen level. Those are your two answers. So that goes in the babies. Strabismus is also, so this is in newborn babies and a peds question. Strabismus is also in the children, crossed eye. That means the eye muscles are weak and they have diplopia problem. And the third line, how do you really know they have a problem? They're tilting the head or squinting. So it's called tinting or squinting. What do you do? Eye exercise. How do you give eye exercise? Write down the two things. Patch the eye. What eye? Good eye. And atropine eye drop in a good eye. So what happened? They're using the weaker eye and they can use that and you can treat them by patch and atropine eye drops. Are we clear? So give them exercise. Retinal detachment question can be in adult. Those two are more in the peds. Detached retina means the inner layer of the eye is moved away, is not in the place. So what does the patient feel? Underline the word flashes and write down the word. They feel like a curtain and they feel like it flashes in their eye and loss of vision. Or maybe they're feeling a line is moving and it can cause confusion. Yes, they do have a problem in vision. That's a loss of vision is important. Then you go flashes of light is important and curtains or veil. Sometimes they use the word like a veil is coming in front of their eyes. Now what do you do when patient comes in detached retina? There's nothing much we can do as a nurse. Your answer would be bed rest. And what position do you turn them? On the same side. Prevent the movement of the eye. And what side do you turn them on dependent position? Number 3 is eye patched. You can either cover one eye or both eye to rest the eye. So main thing, rest the eye, don't let them move. And also sedative. You give them sedation so they're not nervous, they're not moving around. Avoid stooping, straining, and stool sternus activity for 3 months. This is after surgery. So what they do really is they will do the surgery, and what is the name of the surgery is called scleral buckling. So make sure you write down the word scleral, S-C-L-A-R-A-L, scleral buckling. So when they come back after scleral, so what did they do in scleral buckling? They are pushing back the retina and they're using the in their gas and the liquid to keep it in position. So what position do you do when they come back after surgery is very important. Keep them on a prone position and affected eye will be up. So what happened? They turn the head like this. If they have done a right eye surgery, this should be up, but they're laying on the stomach. Are we clear? And they can, if they're sitting up, they got to move their head downward, stooping. So prone position, affected eye will be up. So remember, that's affected eye should be up. And that would be your treatment. Now remember, no reading, no straining, and avoid stooping and activities, especially the eye. No watching TV, not reading, at least until the doctors will tell them a month or 2 months or 3 months that they cannot read. So they got to give rest to their eye. So everyone understand detached. How do you get detached retina? Maybe accident or maybe a blow to the head, and that can lead to separate the retina. And some people, when you're getting older, that can happen. So older people and blow to the head. Cataract. What is cataract is? Blurry vision. Underline the word. Milky and white and opaque. Opacity of the lens. Sometimes they give the word opacity of the lens. That means the lens is problem in the lens. So what is the problem? Blurry vision. Mostly cataract is in the old people. It's an older patient's disease. And what do you do when you are giving them this cataract is post-op care. Check for bleeding. When your patient comes back, check for bleeding. Check the pupil constricted with lens implanted and dilated with the without the lens. So check the pupil, but very important, hemorrhage and pain. At there, if patient complains pain and there is a drainage, you need to notify the doctor. But very important, they need to continue eye drops and they need to follow up the doctor's appointment. So write down their follow-up. They go next day to see the eye doctor. And also, as the doctor gave them eye drops, they should put eye drops. In the night time, eye shield. They need to put the shield. What side they should turn? Unaffected side. So if it is right side, they can lay on the left side. Now remember, avoid shower, because shower, the water goes straight to the eye. Bath is a good. Avoid all your eye surgery, constipation, lifting more than 15 pounds, not good. So add there all your eye surgery, prevent constipation, lifting is not good, bending is not good. And for cataract, avoid shower. Bed bath is good. So that covers your cataract. Follow-up appointment, eye shield is important, and safety. Write down the word safety. Because they're older people and they cannot see clearly, they can fall. So make sure ambulate. Whatever they're using, walker, cane, and help them to walk and prevent them from fall. In the hospital, cataract surgery, you don't stay. You go back after a few hours home or wherever you came. Nursing home patient will go back nursing home. If you have an appointment from home, then family member stays and they take you back. Next is glaucoma, is increasing, underline the word, intraocular pressure. What is a glaucoma? 10 to 22. Some books you have 10 to 21, but that's okay. So up till 22 you consider okay. If it is more than that, that means patient has glaucoma. How do you check the glaucoma? Write down the word tonometer. What are we using here? Tonometer. And you're checking the eye. Now underline the word decreased peripheral vision. That's important. What kind of vision loss in glaucoma? Peripheral vision loss. And the patient is complaining pain and headache. Write down on the side sign of acute glaucoma. So if they are having really a lot of pain, that means the pressure is very high. And when the pressure is high, it can lead to blindness. Are we clear? So what is the sign of? Is patient is having severe headache. What medication do you give when they have acute glaucoma? Write down underneath is called, what is the medication you give them? Mannitol. Write down the word mannitol. You can give mannitol IV and it reduces the pressure and also you're losing potassium. Are we clear? It's like a diuretic. So if your patient is having acute glaucoma, you must treat right away. Otherwise they're going to go into blindness. And what do we do when they have this? You give them diuretics and reduce the pressure. And what medication is commonly given? Mannitol. Mannitol is also given for ICP. So remember, any question, it's a osomitral is diuretic. So it's a diuretic. Now, I will go on other side of the page. So we already know acute glaucoma. Any question, give patient has glaucoma, but patient complains severe headache. What do? It must be treated. Otherwise, they're going into blindness. And we all should know glaucoma lead to blindness. So what do you teach your patient? Your teaching question. They must put eye drops regularly and follow-up appointment. Now, what medication do you give? Miotic. What is miotic is? Constricting the pupil and draining the fluid. And what fluid is it draining here? Aqueous humor. And then you will go is patient R, and then surgery will be done. If that didn't help, avoid lifting and straining. All your patient with eye constipation is not good, stool softener is good, avoid lifting. Mydriatics medication will dilate. Underline the word contraindicated with glaucoma and write down the drug they give you in Nclex, no atropine. Do not put atropine in their eyes. Now what are the drugs you have for glaucoma? Make sure you already wrote mannitol, and you must write down Diamox is another medication, and you lose potassium, these two drugs. Then you have Other medication, mannitol, Timoctic. Make sure you can write thing, Timoctic. Timolol, if they give you, that's also Timolol and Timoctic. Are we clear? And pilocarpine. But remember, these are all, if they give you what drugs are myotic constrictor pupil. So these are myotic drugs. Are we okay? So everybody, you got to remember your teaching questions. Your patient has this, patient going home, what do you teach them? So those are important when we are talking on that. Page number 37. Trigeminal neuralgia is, write down, fifth cranial nerve. We already talked about it. Another name of trigeminal neuralgia, tic-Delarue. So make sure you guys remember that. And where is the pain? Underline the word facial pain, twitching of facial muscle. What medication do you give trigeminal neuralgia? Is your seizure medication, that is tegretolol. Underline that word. On the second side, soft diet. Write down there. Make sure you give your patient soft diet. Let them eat on unaffected side. Also, do not give too hot and too cold food. And avoid cold air in the room, or they use the word draft. Do not move quickly. Anything can cause pain. So remember, you protect them from pain. So trigeminal neuralgia, what cranial nerve is affected? Fifth. Then you go Bell's palsy. It's a facial paralysis. And seventh cranial nerve. So make sure you guys have seventh cranial nerve. Inability to close eyes. And also lacrimation increase. Their eyes are draining the water, because if you see, when you're paralyzed, your eyes are not working, and what happened? We are draining more eye drainage. And what does it can cause? Risk for eye infection. And face is moved to one side, this clotted side of face, just like in a stroke patient. But this comes from some infection, and it comes and it goes away itself without any treatment. But what do you teach them to do here? Isometric facial exercise, and also prevent eye problem, abrasion. Maybe you close the eye, or eye drops, artificial tear drops, washing out. Maybe special eye drops, maybe eye care. Are we clear? Anything with eye, you take it. We did already GBS yesterday. And it's in neuro. And what is GBS is, remember, ascending paralysis. We said what a paralysis? Ascending, going from leg. What is the biggest problem with GBS patients are? Respiratory, swallowing, and their bladder can be affected. The legs are very weak. And eye care is important. So remember, they're going from leg, but the first thing always remember is your respiratory, swallowing, then maybe the bladder problem. And how do you get GBS? Remember, it's immune disease. How do you treat them? IV immunoglobulin and plasmapheresis. Are we clear? Now, meningitis. I will move on meningitis. Now, what isolation do you take your patient in meningitis? Is a droplet precaution. How do you get meningitis? From infection. What is the early sign of meningitis? Knuckle rigidity. Kerning sign are the knee and the leg. Brudowski is the neck. They become very stiff. Also, I want you to add their fever, high fever they have, meningitis, and photophobia. They're very sensitive to light. So what do you do? And bulging fontanelle, high-pitched cry would be sign of ICP in the children. Now, underline the word seizure. What are you preventing your patient who has meningitis? You want to prevent them from seizure. Meningitis medication are antibiotic. So what do? You put them in isolation, droplet, and start antibiotic and prevent the complication from droplet precaution. I want you to add also in sign and symptom with meningitis. They have rash which has red macule. So add their rash with red macule. So some of them, they have rashes with the red macule. And also antibiotic, you give them quiet room, non-stimulating room. and assess for their seizure and airway. Make sure, because if they start seizuring, maybe they have problem with the airway and they become very stiff. Next is thoracosynthesis. Where do we do thoracosynthesis? You're going in the lungs. What position do you do for thoracosynthesis is sitting upright. You can sit upright, leaning on the table or laying sideline position. Where do you insert the needle? I want you to write down the word pleural space. So where do we insert the needle? In pleural space. Pleural space between the lung. What do you teach patient before thoracosynthesis? What do you teach patient? Not to move, not to cough, give a cough medication, and also no more than 1,000. Whenever you're removing fluid, the best thing is don't go more than. Sometimes they might say stop after 700, 800. What do you monitor after thoracosynthesis? Shock, they can go in shock, hypotension because you remove fluid. And when the patient come back, let them lay on unaffected side. And what do you monitor? Pneumothorax, collapse of the lung, and breathing problem. If there is a breathing problem, you need to notify the doctor. So you should know completely thoracosynthesis, not only knowing one line, but the position, needle inserted in pleural space. EEG, you're doing EEG, electroencephalogram, that's for the brain. And what is important is, next is second line, you are checking for the brain, that is the first line, and hold tranquilizer, stimulant, and depressant. So what are you holding? Any seizure medication. Are you holding your tranquilizer? Yes. Any sleeping pill? Yes. You want to go for at least 24 to 48 hours. So what do? You hold the medication for 24 to 48 hours. And then what do? Tell the patient to hyperventilate. Keep awake night before the test, also to check their brain activity. But very important, I want you to write down, wash the hair before and after. So after patient come back also, maybe you need to do the washing their hair. When the patient come back, remove the paste, means wash hair. After procedure, they have a lot of, is the ointment in there or gel, you got to remove from hair. Underline the word withhold medication, now you can give them back. But monitor for seizure. Write down safety, because you were not giving medication, and that they can go into seizure. So always neurological assessment, and seizure sign are epigastric distress, light before the eyes. So they start feeling aura. Aura means before seizure. So EEG, everyone should know, you got to hold the medication, wash the hair before and after procedure. CT scan. When you're doing CT scan, dye, give flushed, warm feeling, metallic taste. So write down the word check for allergies. Are we clear? So CAT scan, check for allergies. Myelogram, we already talked about it, 8 to 24 hours supine. And head raise, 30 to 45 degree, 8 to 16 hours, when they have water-soluble dye. So if they have oil-based dye, you keep them supine. If they have water-based dye, then you will raise the head. Now, liver biopsy goes in GI system. Now, this is, we talked about neuro, meningitis goes in neuro, GBS goes in neuro. Now, I'm on liver. We all know where is the liver. Liver is on the right upper quadrant. Position, number 1, vitamin K. Also write down, check for bleeding and clotting time, because patient is going risk for bleeding. So what do you check? Bleeding and clotting time. NPO is important. You do need to get consent. Sedative. Position. Put them on supine or lateral with arm elevated. You got to keep this arm away so they can keep up on when they're laying, expose the right side. So if they cannot lay on supine position, you may put them on lateral or on the left side. So write down the left side. Left lateral position. You are turning on the left side. Tell the patient not to move and hold the breath when they are injecting the needle, because so they will not puncture the liver. So very important, tell them not to move, not to cough, and hold the breath. When patient come back, position on the right side. It says operation side. What is operation side? Right side. And also for 1 to 2 hours, and also write down, keep the pillow. And sometimes they use the word hypochondric region. Hypochondric means where your GI and the liver. So you put the pillow right on this area and it applies the pressure. Gradually, after 2 hours, you can start elevating the head of the bed. First you do 30 degree, then 45 degree. Very, very important, your patient don't walk right away. Bed rest for 24 hours. Check the vital sign, check the bleeding and clotting time, and monitor abdominal pain. I want you to add there. When your patient come back, prevent them from constipation. Lifting, because they can lead to bleeding. So constipation, lifting, and also when patient is going home, constipation, lifting, both of them again would be important when they're going home, and to prevent them the intra-abdominal pressure. So if they're coughing and they have pain, that you need to notify. Upper GI series. What is upper GI? I want you to write down when their patient is going for upper GI, which patient they're looking for in upper swallowing problem, upper GI. There is upper, and write down the word lower GI. And when they're doing upper GI and they're giving lower GI, and it says here is barium swallow. Now upper GI, they give them barium to swallow. This one, lower GI, they give from rectum. And this one, they're looking for swallowing problem. And here in the lower intestine, they're checking if they have any problem in the intestine. So they are giving barium. But everyone remember, when they're saying upper GI or upper GI series, barium swallow, write down the word X-ray. They're going to do X-ray. So no metal. If they have a question, patient is going upper GI or barium swallow, answer would be remove X-ray and remove all your metals. Remember, remove the metals. Anytime you're doing X-ray, remove the metal. Then you remember, is barium cause constipation? So when your patient come back, check for constipation, fluids, maybe another answer, laxative, maybe another answer, and the stool color would be white. What color would be the stool? White. Are we okay? So stool color would be white. So you are done. Same thing with lower GI. Tracheostomy, tube cuff, and you use the tracheostomy cuff to prevent aspiration. Now they said, when do you inflate? So everyone, tracheostomy cuff tube to prevent aspiration. Continuous mechanical ventilation. If your patient has ventilation and you have tracheostomy, you do cuff. During or after eating. During 1 hour after tube feeding. When patient cannot oral secretion, then you may have to do is inflate the cuff, and it's called cuff tube. So that is important, goes in your tracheostomy patient. Oxygen question, very important when we are talking about oxygen. Do not go too much with nasal because you get very little. Face mask. When you're giving by mask, you're giving about 40 to 60% of oxygen. Partial rebreather, 90%. Are we clear? And partial rebreather is very good in which patient? Respiratory alkalosis. Write down the word. Respiratory alkalosis question. They are hyperventilating. You want them to breathe back their oxygen. So what mask are you going to use? Partial rebreather mask or paper bag. And you're using for respiratory alkalosis. What is respiratory alkalosis? Write down hyperventilation. When you hyperventilate, you are going to go in alkalosis. To prevent alkalosis, you give them partial rebreather mask. Non-rebreather mask is good when you want to give 100% oxygen. Write down like pulmonary embolism. So if you have a patient, pulmonary burn patient, you give them this answer, burn and pulmonary embolism. Venturi mask is good for COPD patient. Why? Because provide high humidity, but underline the word fixed concentration. What is the meaning fixed? Whatever the amount you're going to give, patient is not going to get more than that. And how much do you give for COPD patient oxygen? 1 to 2 liters. So some question I was doing, and there was a question, what mask are you going to use for COPD patient? And answer was Venturi mask. Are we clear? So now you know where do you use this mask. Very important that you know. Now tracheostomy and collar and T-tube is, remember, some patient has T-tube. And T-tube means 20 to 100% mist, underline the word mist. They're getting the moisture, mist. And keep the water container full. So remember, when they are attaching with tracheostomy T-tube, they have a mist coming to the trach. So you've got to make sure the water bottle is always have some water. Croup-petit word and oxygen tent goes in Pete's question. Child is in oxygen tent. Remember what kind of air they're using in, they're getting oxygen, but line 2, cooled, humidified air. What are they getting? Cold, humidified air. And what do? You fill up with the distilled water and daily, and cover patient with blanket because they're getting a lot of humidity. So number 2 line is good. Number 3, very important, cover the patient with a blanket, child, and a cap, and make sure the side rails is completed. Now remember, oxygen tent is getting moisture air. But also do not remove the child from the tent. They got to stay. Mother can only touch them because they need to get more oxygen. So don't remove the child. Next page, we'll move on, is you have change linen, because what happened, the linen gets wet. Continuing with that, and monitor patient temperature. Always check the temperature. Now, chest tubes, you remember I gave you the tubing, and we have talked about the chest tube in the pictures, and the one package I gave you where you have all the pictures, and you have chest tube implementation. Used to utilize negative pressure in lungs and water sealed chamber. Remember your second bottle, you guys have first bottle, that is the patient's drainage. Second bottle, you guys have a water sealed drainage. And the third one is called your suction bottle, okay? So when you have water sealed drainage, so we are on page number 39, and that goes with the water sealed drainage. And how much water do you have? Sterile water, around 2 centimeters. And what do you monitor? Suction control chamber with sterile water. So suction bottle also has 20 centimeters of water. Maintain below the level of insertion. All your bottle, all your drainage, always remember below the level, because you don't want them to go back. And clamp only when there is a leakage really bad and you want to stop, then only you clamp. Milking, I will not advise you to pick up answer milking to the tubing towards the drainage. You can do that, but they avoid not to do the milking. But observe for fluctuation. Underline the word fluctuation. Where? In second bottle, write down water seal bottle. So fluctuation is normal in water seal bottle. Encourage patient to change position frequently. Now, mostly which side you should turn them? On the same side where you have tubing, and so it helps them to keep the tube on the both sides. Are we clear? So next is water seal drainage. Fluctuation is normal. If your question is your fluctuation, I'll go over. Let's highlight the wording here. Instruct the patient to do Valsalva. If you are removing chest tube, what do you do? In a second box, instruct the patient. You know what is Valsalva? Pushing. Clamp. and remove quickly. So this is your answer for removing your chest tube. And you apply a dressing occlusive. Don't allow the air to go in. Same answer, if the chest tube come out accidentally, immediately you cover with what? Occlusive, dressing, or Vaseline gauze. You can add there if patient pulls out the chest tube. Complication of chest tubes are constant bubbling. In water-sealed chamber, air leak. If there is a bubbling here, water sealed, second bottle bubbling, it shouldn't be a bubbling. So that means there is a leakage. What is normal here? Fluctuation. Everyone is okay? Fluctuation. Tube become dislodged, then dressing tend to one side. Tube become disconnected, then insert sterile connector and reinsert that. So if your tube disconnected from the drainage system, then you always get a bottle with a sterile water and connect them. Tube become disconnected from drainage system, immerse in the sterile water, which is in the last 3 lines. Now that is good, you guys know what to pull, but let me explain here and you write it. If the fluctuation in your question stop, if the fluctuation stop, the meaning is your lungs have been re-expanded. That's number 1 answer. Fluctuation stop. Number 2, when fluctuation stop, maybe check the kink. Your tubings are good. Number 3, X-ray. Before you remove the tube. And number 4, remove the tube. Are we clear? Maybe you don't need. So what is normal here in the water-sealed drainage is a fluctuation. Are we clear? If the fluctuation stop, that means the lungs may not need this system and the lungs have been re-expanded. So check for kink, X-ray, you do it, and last, everything looks okay, you remove it. So what is normal here is fluctuation. If there is a bubbling, that means there is a leakage and you need to notify. Are we clear? Do not clamp it, but say leakage, notify. What is the third bottle I want you to write down is a suction bottle. What is normal in suction bottle? Some bubbling, opposite. Here is some bubbling. If they're saying lot of bubbling, that means leakage. If they're saying fluctuation, that's not good. So they should not have fluctuation, they should have small bubbling, fluctuation, and that means is there fluctuation, leakage, this may be a leakage, only the normal is small bubbling. Are we clear? So everyone should know how to remove the chest tube. I gave you the pictures in the package. Make sure we all know this, because these are the question, what in the new system they said these are the high area for your Nclex. Are we clear? So we all should know the chest tube. Now I'm going to go CVP line. We have done, but it tells you a little bit more. We all know 3 to 11 was normal, reading which is in the bottom, but let's see, underline the word. What are you checking in CVP? Underline the word blood volume. And what is another word is fluid. Are we clear? So you're checking fluid, you're checking blood volume, and where do they put in the heart? Underline the word right side of the heart, able to manage the fluid. So which side of the heart you're monitoring? The right side. And O manometer at level at right atrium. This is important. Where do they keep the tubing? In the right atrium at maxillary line, and you keep at the level. Are we clear? So this is the level of your tubing, how they keep it, and they turn it in the right atrium and mid axillary line, but they keep it in the shape. Measure the patient in flat. Patient should lay when they're checking in flat. So your question may be, how do you monitor CVP line? So remember the word right atrium in mid axillary line. So what do you do for your patient when you're monitoring this? Patient should be in a bed rest and fill the water with 80 to 20 centimeter, turn the stopcock, and fluid goes to the patient. Level of fluid fluctuate with respiration. Measure the highest level. So what are you monitoring? Fluctuation level, highest level of fluctuation. Now, after insertion, when they insert the tube, what do you need to know? Dry dressing and change dressing, IV fluids monitor, tubing should be changed. And most of all your tubing should be changed in 24 hours. When you instruct the patient, hold the breath when inserted. Withdrawal tubing changed, and so hold the breath when inserted and check and secure all connection. Normal reading is 3 to 11. Are we clear? So what is your normal reading is 3 to 11. Now less than 3, less fluid. Now you guys have on the other side of page, elevated more than 11. That means your hypervolemia, you need to notify, cut down the fluid. If it is less than 3, then your fluid is less. You still need to notify the doctor, continue the fluid. What do you keep in the room is here is chest tray, chest tube tray, in case they have to insert any tubing. So CBP line, very important, keep at the patient is the flat, monitor at the in the atrium, right atrium, maxillary, normal, you should know, changing the tube should be 24 hours. That's all important to know. Irrigation question. Whenever you are irrigating ear and eye, turn affected side. Whatever your side you are irrigating, turn them. Are we clear? Eye irrigation, why? Because the water need to go from inner canthus to the outer. So you turn them on the same side. And you got to keep the wash little kidney tray, small tray, so the water can go. Ear drops, you put the drops, underline the word conjunctival sac, and also press the systemic absorption. Prevent systemic absorption, how? By applying the pressure in inner angle of the eye. And allow the drop to go from one eye to the other and do not squeeze the eye. Don't allow the drop to go from one to the other. Now only I would ask you to remember conjunctival sac. If you're putting ointment, I will ask you, you put the drop first and then you put the ointment. How do you put the ointment? You go not in conjunctival sac. Ointment you apply from inner to outer canthus. Everyone, make sure ointment you are applying inner to outer. If you have to put drop and ointment, you put the drop first and then you put the ointment. Everyone is okay? What do we put first? The drop, and then what do you put the last? Is the ointment. Washing of eye is same way, washing of ear is the same way. Now, Levine tube. I want you guys, if you can take out the tubing package. And if I can just see that, if one of you can just give me, I don't have here. Since it is here, and I want you guys, make sure, I'll give you back, is the single lumen tube. So this is the second tube picture. This is your Levine tube. So make sure you highlight the word Levine tube. And Levine tube is a single tube, and underline the word you are using for tube feeding and decompression. What is the word is decompression? Suction. So make sure you write down the word suction and feeding. Salem sump tube is a double lumen tube. Now you guys have this one. If you look, they have two parts at the end. This is only one ending. So first one is called single lumen. Salem tube, you have double lumen, and they both are used for feeding and decompression. Are we clear? So what tube are you using for feeding? Levine and Salem. But the difference is Levine has one lumen, one end, but Salem has two ends. Are we clear? And next is, you guys have segment and Blackmore catheter. This is the one on the other side. You have segment and Blackmore catheter. And what is segment and Blackmore catheter? For stopping esophageal bleeding, varices. What do you keep in the room? Scissor. How many balloons do they have? It's called triple lumen, used for bleeding. So they have triple lumen. Triple lumen means at the end, three-way, like. But how many balloons they have? Two, right here, and the other one. Why? Because it goes and it gets ballooned and applying the pressure in the esophagus and one on the stomach. Are we clear? And one section of the tube they're using to drain the fluid and the blood. So at the end, they have one lumen for gastric inflation, one has esophageal inflation, and one end is to drain the fluid. So that is called segmentin Blackmore catheter. Now another one also, Linton, you use for esophageal bleeding, but you don't have the picture. But I want you to write down that. And this is called Cure, Fed, and Dufav. You don't have that. It's used for long-term feeding. That's also feeding too. But Cantor, Miller, and Harris is Harris-Cantor. Now you guys do have, you have Miller-Abbott, this one, and you have Cantor on this one. What is the meaning here? You see there is a bulb here, and that is filled with the mercury. So what happened? It goes itself and moves the catheter. So last three one you're using for what? They're filled with mercury, and they have single lumen and suction port and double lumen Miller-Abbott and also suction port, and Harris also has mercury filled. And where do we use this? They are using in the intestinal tube, and also sometimes they use it for irrigation. So these are the different catheters. I gave you the picture. You guys make sure you look, and you look at the pictures and make sure we all know. And I have pulled out the pictures. You guys have this in a Saunders book, and I've taken out from Saunders. And you do have some question on Saunders book. I will advise you to do some question on the tubing and NG tube and suction at the end. 5, 10 question, 10, 15 question. It will give you some idea if you see the question. Are we clear? But you must know, these are, we should know what is Miller-Abbott, what is segmentin Blackmore catheter. So that is good to know. What is the next line? Is the pH of the stomach less than 4? Highlight that word. And when do you know? When you're aspirating and you're checking if the tube is in place. Are we clear? So tube is in place. Sometimes they say check the pH. If your pH is less than 4, is in the stomach. If they're saying pH is 5 and 6, is not in the stomach, is in the further. Tube feeding question. Residual. Underline the word check the residual. And what do we check in residual? Hold if more than 100 and 100. If it is less than 100, then you feed your patient. When do you check residual? Either every 4 hours or write down before feeding. Now, one way we say is 100 or more than 100, but here, line 3. If feeding, hold feeding, if 50% residual from previous hour in adult and 25% in the children. So whatever you had in last hour and you have more than 50% that time, then hold. But a lot of question 100 or more than 100, okay? And when do you check residual? Before your feeding time or every 4 hours. Flush the tube. Always you flush your tubing with your medication when you're giving. And also remember, when you give drugs, you do not push them, go by gravity. You pour it, let it go, and check the placement, flush it before and after. Are we clear? Your medication. Bag can be, if this is an open bag, you change every 8 hours. But if it is your complete continuous feeding bag, they're good for 24 hours. We do not change earlier than 20. Now if you see the one you attach with the pump, they're closed system bag and they're good in a formula. Your patient won't be able to finish within 24 hours. But we do want to change. You can use it more than 24 hours, but usually we change them, the bag and the needle and all their tubing in 24 hours. Are we clear? Now, check the patency. Make sure your tube is okay. Very important, oral hygiene. I want you to write down one more word, semi-Fowler's position for continuous feeding, Fowler's position for bolus feeding. Everyone should know, they ask you that. and tubing you already know, and don't keep in the fridge. Your formula on tube feeding should be in the room temperature. Only you keep TPN in the fridge. Are we clear? So you leave them out. NG tube irrigation. If you are flushing, you should. Now, they don't use the word irrigation. Irrigation means is flushing. So how do you flush your tubing are with, if doctor order is not there, 30 to 50 ml of water. Are we clear? Or normal saline. Usually we use water and we flush. But when they using the word irrigation, then you're using what word? Normal saline. Are we clear? And withdraw and record in the output. After irrigation, what comes out, always make sure you minus from what you put it in and write in the output in any irrigation question. Are we clear? Now next is if you're removing, so you know how to remove chest tube, you know CVP line, NG tube removal question comes in exam, doctor ordered to remove NG tube, what do? Clamp the tube. Is it a sterile procedure or clean procedure? Clean. Wear the regular glove. Are we clear? You don't need a sterile glove to put it in. And instruct the patient to exhale. So what do you tell the patient to? Exhale and remove the tube with smooth and continuous pull. So what do you tell the patient to? Exhale. So that's important. Cantor, Miller, Abbott, and Harris tube. These are called intestinal. Last three tubes are used in the intestine. The what tubing we were doing, those are the last three one. These are the one has mercury, remember, I was telling you. And after the tube is inserted, so if they give you a question, doctor is putting in and write down the word intestinal. Now you have NG tube, and if they're nasointestinal, intestinal tube is done by the doctor. NG tube is done by the nurse. We can do it, but doctor. What would you do when you're inserting this tube? After the tube is in the stomach, so let it go up till the stomach. After it is in the stomach, underline, turn the patient on the right side. And back in Fowler's position, put them in Fowler's position, and gravity help the position the tube. So only you do not tape, and gravity let it go. Coil the table loosely on the bed. Underline the word do not tape. Very important wording is do not tape. So any intestinal tape, after it is gone in the stomach, you leave the head of the bed elevated, turn the patient on the right side, but do not tape. And check by X-ray. And measure is the drainage. If you do have any drainage coming out, you check for that. Removal. Clamp the tube, remove the tape, deflate the balloon. Anytime when you have balloon, you got to deflate. Instruct the patient to exhale and remove 6 inches every 10 minutes until it, now they're talking about removing the intestinal tube. Remove that and completely with smooth and continuous pull. Are we clear? So slowly you're pulling it out. So what they're saying, NG tube you are inserting, what do? This tube are called intestinal tube. They're going further than the stomach. Purpose is not to feed. A lot of time they're opening the obstruction and they're draining maybe the fluid. Are we okay? So there is NG tube, there is intestinal tube. What is your intestinal tubes are? Is Cantor, Miller, Abbott tube, and Harris tube. Are we okay? Now next thing is T-tube. Where do we put in T-tube? Write down with gallbladder surgery. And what is a gallbladder surgery? It's called cholecystectomy. Cholecystectomy word comes, that's a gallstone. Cholecystectomy is removal of the gallbladder. Then one surgery, when they do cholecystectomy, they can put the T-tube and 50 to 100 cc, bloody first 2 hours. And so monitor the T-tube. And what do they attach the T-tube with? Write down the word Jackson Pratt. So where do you have T-tube? In a drainage, and they attach with the Jackson Pratt. Penrose drain. Remember, I showed you in the picture. In those pictures you guys have, you remember that package you have, and there is and the one I gave this morning, and you have the tubing, and you guys have, this is your drainage, and this is your T-tube. This is your Penrose drain. And when they give you Penrose drain, they are putting in the patients after surgery. And sometimes you cannot visualize, and you are hearing. And that's why it's good to know some pictures. Are we clear? So this is a simple rubber tubing, but they put it appendicitis, small surgery, and the drainage is coming out. There is no bag. T-tube can be attached with this one, Jackson Pratt. And Hemovac is also your drainage. Hemovac is a big round container, and it's a plastic, and when you're going to empty, you put on the surface and press it and empty it out and see how much is the drainage. So what is the difference between in this Penrose drain? Expect dressing on drainage on the dressing. There is no bag, so write down there, no bag. What is your priority here? The skin care. What is your priority? The skin care. So make sure you are cleaning the skin, changing the dressing, because it can cause infection. A lot of question can be on your appendectomy patient. When patient come back after appendectomy and they put the Penrose drain. T-tube, they put it in when you have cholecystectomy. Are we clear? And the other one, Hemovac, they can do on a hip surgery, mastectomy patient, and they have more drainage. All right? So everyone should know. The reason I gave you, you keep looking and read them and write it down, and so memorize them. Now, enema. We said, what position do you put it in? Left lateral. Are we clear? Remember in your picture, whichever the picture they have, and this is the right, they're laying on the left side, this leg is going to be more up, flexed. So the buttocks you can see. So right leg is more flexed. That is your left lateral, and they have given in the pictures. So everybody should recognize the pictures. How much your enema can, the fluid, tepid solution. Left side you turn them. What is tepid? Not too hot, not too cold. Write down is body temperature. Another word, and 105 degree. So when you're giving enema, should be no more than 105, but can be as a tepid word and a body temperature. How far your enema can should be? 18 inches. Are we clear? 18 inches. And from the rectum or from the patient's that height. And insert, how much do you insert the tube? 4 inches. Do not use if the patient is having appendicitis, vomiting, and pain. So everyone remember enema. What do you tell patient when you are giving enema? Teach your patient to hold, take a deep breath. What do? Take a deep breath and hold it. So in your teaching question, during giving enema, take a deep breath and hold it. Second thing, if they ask you, patient says, I'm having cramping, what do? Stop. Or lower the can. Sometime when you see what happened, the can is high, pressure is high. You lower the can, the pressure would be less, the water is not going in. So either you clamp the tubing or stop the enema or lower the can. Next is, what do you do after enema is given? What do you do? What do you do after enema is given? Aren't you going to see your patient had a BM? Check the result. Your patient has a BM, how much BM? Is it came out good or not? And also tell the patient to hold it. If they hold it, it works better. Are we clear? Deep breathing, hold it, temperature, 18 inches, very important. Catheter insertion in urethra. In female, you go 2 to 3 inches. Female position is recumbent position and knee are flexed. Are we clear? I gave you the pictures. What do you do after it's in urethra and urine is coming out? You insert a little bit more. And in male, urethra, you are going, is longer, so you go 6 to 7 inches. Male, what is the position in male to insert catheter? You don't bend the leg. Leg should be straight, hold the penis in hand and insert the catheter. When you're cleaning, you go rotating. Are we clear? Clean external area before you insert, but hold the penis, but not leg is not flexed. Keep the leg straight. Remember, you got to tape the catheter. After you insert, either you're taping in lower abdominal area. They're saying it's better to tape here than tape on the leg because when you're moving, you can remove the catheter. And why do you tape the catheter? So prevent what? Pressure. What happens if you don't tape it? The tube is, especially in male, the tube can cut the area and they can have a lot of skin breakdown. So do that. Catheter drainage bag. When you do not remove more than 7, if you are putting catheter for the urine, if the urine, you are inserting a catheter, clamp it if it comes about 700. Why? To prevent shock. They can go in hypo. Let me finish here, then we'll take a break. Ileostomy, patient has what? Green, dark green liquid drainage from stoma. Ileostomy means is the loose BM, green color BM, and their drainage. So remember, a skin care is important. Let's take a break, and then we'll continue some more on that.